So to continue what I was talking about as regards the renal complications of liver disease, I already talked in my first presentation or mini lecture just a few moments before about the what we call the hepatorenal syndrome and the possible involvement of both kidney and the liver in systemic diseases. Let me continue what I was talking about, the renal complications of liver disease, and let's start by talking about what we call the renal dysfunction in patients with cholestatic liver disease. That is patients who are having a liver disease with jaundice, whether hepatocellular or obstructive jaundice, which are the two types of jaundice which might be met with in patients with liver disease or hepatic insults. And to be more specific, in patients with obstructive jaundice, whether it is due to intrahepatic cholestasis or extrahepatic cholestasis. Most common forms of intrahepatic cholestasis are the primary biliary cirrhosis, and in patients with primary sclerosing cholangitis, and the extrahepatic cholestasis most commonly is biliary calculi, obstructing the common bile duct. Or the branches of the common bile duct. This is biliary obstruction. In patients with cholestatic liver disease, they might get a group of defects, most commonly acute renal injury, which might be either due to pre-renal factors or renal factors due to acute tubular necrosis in patients with cholestatic liver disease. The acute kidney injury in patients with cholestatic liver disease is usually multifactorial, ranging from being secondary to hypoperfusion, renal hypoperfusion due to either due to vasodilatation or due to what we call intravascular hypovolemia, due to retention of bile in such cases in the circulation, and the bile has deleterious effects on the cardiovascular system and the cardiovascular function. And among these resulting problems is the intravascular hypovolemia, and the intravascular hypovolemia will cause a form of renal hypoperfusion, and this might cause acute renal or acute kidney injury, or it might be related to tubular obstruction by bile casts, or direct injury to the renal tubules by the bile. So there is various forms of tubular defects and also glomerular defects in patients with cholestatic liver disease and cholestatic jaundice. And this sensitizes, in fact, this sensitizes the kidney to pre-renal failure or acute tubular necrosis in post-surgical patients with obstructive liver disease or obstructive jaundice. In post-surgical patients with cholestatic liver disease, they might be susceptible to a form of pre-renal failure or acute renal failure due to acute tubular necrosis, due to the either related to the hypoperfusion, due to hypovolemia or intravascular hypovolemia, or related to direct or indirect tubular injury by tubular bile casts, or by the damaging effect of the bile acids on the renal tubules. So it is rather a multifactorial and complicated relationship. But tubular injury is common and also glomerular injury is common in patients with cholestatic liver disease, leading to some form of renal failure and renal dysfunction. This is a point. Another point is the development of glomerulonephritis in patients with viral hepatitis. It's well known that patients with, to be more specific, hepatitis virus B, they predispose the kidney to development of some forms of glomerulonephritis, namely membranous glomerulopathy and the mesangiocapillary or the rapidly proliferative glomerulonephritis. So the rapidly proliferative glomerulonephritis or the mesangiocapillary glomerulonephritis and membranous nephropathy are possible renal complications of viral hepatitis B. And as regards viral hepatitis C, it causes also another form of glomerulonephritis, which is cryoglobulinemia related or cryoglobulin associated glomerulonephritis. And whether the cryoglobulin associated glomerulonephritis of hepatitis C or the membranous nephropathy and the mesangiocapillary glomerulonephritis of hepatitis B, they both can lead to different clinical syndromes, including mild to moderate proteinuria. This is how they present clinically. They might cause mild to moderate proteinuria or nephrotic syndrome, or frank renal failure. So this is the clinical spectrum of presentation of a pathological involvement of the kidney by glomerulonephritis in patients with hepatitis B and hepatitis C. They might ultimately present with nephrotic, proteinuria, hematuria, nephrotic, or renal failure. Classic frank clinical renal failure. So glomerulonephritis is a complication of viral hepatitis B and C. As a part of direct involvement of the kidney, or as a part even of some cases in some patients of systemic vasculitis. Especially hepatitis C, they might cause some form of systemic vasculitis, which might involve the renal vessels also, especially the renal small and medium-sized vessels, leading to kidney damage and renal complications and renal failure. So either by direct involvement of the kidney or being a part of systemic vasculitis involving the kidney vessels as well, by renal vasculitis. So this is another way of renal complication of viral hepatitis B and C as primary liver diseases, common liver diseases. Then this is as regards how the kidney might be a complication of a primary liver disease, as I mentioned. The other way around is the liver complications of renal disease. This is rather rare or uncommon, and the most common forms are two clinical categories. What we call the nephrogenic ascites, which might mimic liver cirrhosis with ascites, but here in nephrogenic ascites, the ascites is renal in origin, not hepatic in origin, but they might look like a cirrhosis with ascites. So in the cirrhosis ascites, the differential diagnosis is nephrogenic ascites, that is ascites complicating the renal problem, for example, like the ascites complicating nephrotic syndrome, and nephrotic syndrome due to an underlying renal pathology. And here the treatment is renal transplantation. And consequently, this will help the nephrogenic ascites to be treated or cured. Another condition is what we call the nephrogenic hepatopathy, which happens in patients with renal cell carcinoma. And this is which is not related to hypernephroma metastasis. It's not a metastatic manifestation of the primary renal cancer, that is the hypernephroma or the tubular cell carcinoma, which is of tubular origin. It is a non-metastatic manifestation of the renal cell carcinoma or the hypernephroma, which improves by removal of the renal malignancy, by removal of the malignant kidney. The liver functions will improve, and this is what we call nephrogenic hepatopathy or nephrogenic liver disease in patients with hypernephroma of the kidney, which is common renal malignancy. And it improves by the removal of the renal tumor. Many of such cases we might need, especially in patients with chronic liver disease and chronic renal disease and with ascites, we might need both kidney and liver transplantation together. For example, doing a liver kidney transplantation without liver transplantation will not cure the condition and might make the clinical problem more serious and deteriorate the condition of the patient more. That's why both the kidney and the liver should be evaluated together, especially in complicated cases with advanced kidney and liver disease, and with advanced liver and kidney dysfunction, and have to sort out the problem. Is it in the kidney to start with, and then the liver is involved, or it started in the opposite way around, that started in the kidney and then the liver is involved, and we have to assess both the kidneys and liver in such cases with end-stage renal disease and end-stage liver disease at the same time for consideration of both liver and kidney transplantation to be done together in the same patient. This is as regards, for example, the involvement of the relationship between the liver and the kidney in disease. Thank you so much, and I will see you in other presentations in the future. Thank you so much. Professor Tarek Ali.